Well, Dinorah and I are both faculty here at Texas State in the graduate program, the family nurse practitioners, and I have probably about 31 years now of experience of teaching medical students and nursing students. And so what we're about to tell you about our approach to role play and simulation is low tech. And we're learning so much from you today that we can move forward. But we have a love for this role playing and for this teaching and experiential learning, probably because we're in clinic and we have students at our elbows. And therefore it's not very new, is it? It's because Aristotle has said, for things we have to learn before we can do them, we learn them by doing them. And so that's really was the objective that we had in preparing and evaluating advanced practice nursing students' competencies in independently being able to provide women's health care. This course is embedded in reproductive, sexual, and obstetrical health, and just for all the gentlemen in the room, we do have men involved and we do have content for that and we do work with that, but just for this presentation, since it needed to be so short, we would just focus in on the women's health aspects. There's 32 students, so Dinorah was the didactic instructor for 16, and myself for the other, and we worked together during this 10-week course. And our students in our program are predominantly online. And so we have them visiting our site for 2 weekends during that semester. So we have 16 hours to do everything we would possibly want to do with them. And of course, us to be able to nab some of those hours was really a coup on our part, so we're glad to do it. So the pre-work that's included in this course is really for talking about the simulations too. And it's individual and group work. And we have instructional designers that really help us pull these teams together. It's really beautiful. I've worked where we haven't had that kind of resources, but they really are a part of a team. So the clinical groups that we worked with as clinical faculty were 6 or 7 students, and these students knew each other. It was very personal relationships that they had, and ones that they had started at the beginning of the program, so this continued on. So we used very low fidelity simulation and standardized patient vignettes, which are, in my opinion, shorter than real simulations. And the implementation is with real people, because what we have not been able to find in the literature is how does it translate to that clinical practice. But since we were their clinical faculty and we were reading their patient case studies and interacting with the patients, we were able to evaluate whether what we did here was really being carried forward. So that's the rationale. You know, it works. Simulation works. Across the United States for advanced practice, the simulation hours are not counted for clinical. So this is above and beyond the 640 or 700 or 800 or 1,000 hours that's required of advanced practice. And there's little evidence that exists that it impacts the clinical component. And it is very skinny on what happens after the professional registered nurse level. Very little graduate. So our specific aim was to evaluate and determine their skill competency after that. After they had done their checkoffs, their OSCEs, we determined that they could do a pap smear and these other things. Does EduLAR experience prepare them? Is that how you say it? EduLAR?
EduLAR.
But now I can't hear you.
EduLAR.
Thank you. Prepare them for clinical practice via telehealth. Now, the reason telehealth is because, as well as health informatics being an advanced practice nurse competency that's mandated, so are using the computers and using telemedicine. So our methods were that we used TRACS as the platform, and that is a self-run program within Texas State, very similar to Blackboard or Moodle or those others. And that was designed for our online learning modules and assignments. And we had 3 hours of face-to-face, low-fidelity mannequins to use in the small groups that I described to you previously. And the faculty acted as the standardized patient. And the vignettes presented were really based on the faculty doing that role play, but building on what they had heard or read in the clinical experience in the notes from the students coming in. So we'll share that with you.
So building on the pre-work, so how do you make an online course engaging when you're at home clicking on your computer? Well, it was difficult to go from your ordinary to your extraordinary situation, to be creative, to engage them so that they would be able to interact with us through innovative assignments. They had the weekly readings, quizzes, forums, discussions where students needed to engage and talk to one another and explore where they have been and then move to where we need them to be. So we used some innovative assignments. For example, we had them do some common pregnancy discomforts as pre-work. We filled them up with information, we built them up with and equipped them with the tools they needed in order for them to actually go out there and actually do the simulation when we did meet with them on that weekend. And then when they were going to actually implement it in telehealth, which was, we were excited, we were like holding our breath. Well, not really, but anyway. So we used common pregnancy discomforts teaching tool. We had the students, I believe, do a teaching tool for their patients. And so the students had to learn how to put the most common information for brand new pregnant patients so that they would know what to expect. And of course, this kind of talks a little bit about the second trimester complaints. What are the most common pregnancy complaints? The third trimester complaints, and then of course, they formed it into a pamphlet where they would be able to print it out and give it to their patients in the clinical side. The other one that we used was the standardized electronic medical record that Dr. Willson will talk about in just a minute, which is really linking the learning experience to the telehealth portion of it, which was kind of exciting. We also did a contraceptive toolkit that allowed students to, as they put this information together, they also learned it themselves. And they went through all different types of contraception for those patients that are going to be initiating contraception, those that are going to be postpartum, that they've delivered and they're giving ideas or suggestions for contraception. And then lastly, the clinical breast exam teaching video. This was, we simulated this and role played during the weekend with with an actual model, if you will. And then from there, we asked our students to go ahead and provide us, here's the EMR, and the contraceptive toolkit that we asked them to go into. Again, we asked them to include how to use them, the effectiveness, the standard errors and follow-up and teaching for their patients. And actually, they could also use this toolkit as a handy reference when they're in the clinical site. Here's the clinical breast exam teaching video that one of our students provided for us, and I think we can go ahead and play that.
Or part of it, for sure.
Part of it.
So what she's described are individual products from the course, but those were developed via this group interaction with the students, except for the parts that we were going to evaluate.
I'm a nurse practitioner student at Texas State University, and today I'm going to go over a clinical breast exam. A thorough breast exam starts with a comprehensive personal and family history. If you were older than 35, a breast cancer risk assessment tool score will be obtained to estimate yours or any woman's risk.
So now we're giving the evaluation of whether they actually learn that clinical teaching exam, which is what advanced practice nurses do. We're teaching the entire time that we're doing our assessments on our patients, and then they were received an evaluation or an assessment grade for this particular one. So the students were here on campus now for the 3-hour. We're off the online and here in our exam rooms, or in the auditorium across the way, actually, because we had so many students in breakout sessions. And marvelous, okay, 5 minutes. So I'm going to go faster. So here are the OSCEs that all of the students had to complete in order for us to know that we could let them out the door. The Leopolds for determining the pregnancy positioning, fetal heart rates, and adult gynecology. So let me just tell you about the vignettes. They checked off on those. We had matched that standard examination. And then we would go on into doing vignettes. And that would be different for each group, but we decided as faculty we would cover pregnancy, pediatrics, obesity, and elderly patients because those are some skills that they definitely need. So we, as I said earlier, we built on what the students had said.
What we did in simulation and incorporating EduLark was the clinical faculty for each group, we role-played specific patients. For example, for my group, I'd say, well, I'm 15 years old, my mom's waiting for me in the waiting room. And so my girlfriend just started on birth control. Can I get started on birth control without my mom knowing?
Except for she said it in Spanish.
Quiero contraceptivos. ¿Cómo le hago? ¿Qué es lo que va a pasar? No quiero que mi mamá sepa. So after that, it was, what are you going to do? How are you going to do it, and why would you do this? And so it was a continuous interaction in terms of the faculty also role-playing the patient and the students giving us feedback. It was almost a continuous debriefing, if you will. It was formative and summative at the same time, kind of like that. Because as advanced practice nurses, these students are already registered nurses, so they bring something to the table already. And so what we want to do is we want to build on what they already know. Some of them were OB nurses, and they understood what we were talking about.
I'm going to move on because we have a 1-minute sign coming up here, Dinorah. How did that happen? It always happens.
It's in Spanish.
The vignette that I did with my clinical group was because one of their TICON notes had been in emergency care, and they had told all about their visit, but they hadn't told me that a woman coming in with vaginal bleeding was 14 weeks pregnant, but they didn't do fetal heart tones. So I'm going back, where are the fetal heart tones? Certainly you forgot to record that. And he goes, well, no, I didn't forget, but the provider said not to do it because we didn't want to worry her. So then that gave us a wonderful opportunity for us to go into the ethical, legal, and why that rationale seemed kind of good at the time and wasn't. But since it was in the small group, they didn't have to volunteer who they were. I just told about it. And so they were, the student that we had already had previous communication with was the hero of the day, because he goes, oh, you've got to do that. You know. So it was a way for us to make sure that they learned about how to do pelvic exams on persons with disabilities and all those sorts of things. And we'll be happy to share those little details there. We ought to write a book about that, actually. So the telehealth implementation was after all of the simulations and the pre-work, and they actually assessed patients doing all of the type of prenatal care that an advanced practice person does, and counseling and teaching, and they were able to do that with one initial face-to-face visit. They contracted with this patient, they had signed consent to be with this patient, and they followed up with them in 3 telehealth modalities, which is either telephone or video streaming or other secure kinds of video conferencing that we have available here or that they had available in their institutions. And we were able to note that they had that evaluation because we were assessing them and acting as their preceptors as faculty after every visit.
That's basically it. There was, the good news was that there was, after evaluation, there was a high level of satisfaction from the students, from the engagement of the innovative assignments, where they were able to learn, be able to show us, and then be able to implement it, which was beautiful. And also there was some patient satisfaction as well, when it was presented to the patient, so.
As far as the electronic medical records, oftentimes when they're with a preceptor, they're only an observer of the electronic medical record because of securities. So this gave them an opportunity to use an electronic medical record which they owned, and then was able to summarize and give back to the patient so they could take to their primary care provider. And so they were in charge and happy about it. So our recommendation is that we continue this kind of process and maybe move it across the curriculum. And now I think we also put it into gaming.